Hello, it's my pleasure to give you again a lecture about hypertension, but today the lecture is going to be with a twist. It's Hypertension Update 2023. Now, a great physician once said, the great danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. Don't worry, these are not the new guidelines for medication. This is actually what renowned physicians thought of hypertension in the 1930s. A lot had changed since then. We have now realized that hypertension is a dangerous disease with many complications that need to be treated. Since I've last talked to you about hypertension, there has been, actually just 1 month ago, a release of the European Society of Hypertension guidelines for the management of arterial hypertension, together with the European Renal Association and the International Society of Hypertension. Now, there are multiple factors that are involved in blood pressure regulation and the pathophysiology of hypertension, and the guidelines offer a view of the most recent. Now, still the brain, the heart, and the kidney, together with the suprarenal gland and the blood vessels, are central in the control of blood pressure. But there is realization that there are multiple factors at play. For example, there are few monogenetic factors, but many polygenetic factors that predispose to hypertension. Lifestyle factors like diet, alcohol, smoking, physical activity, sleep quality, and stress. Environmental factors like air pollution, noise exposure, and also the temperature and the global warming is being blamed increasingly for many of the diseases that we are experiencing. And there are multiple factors or humoral factors that are involved in either increasing blood pressure or decreasing blood pressure. Increasing blood pressure like RAS blockers, RAS like renin-angiotensin aldosterone system, the sympathetic nervous system, endothelins, vasopressin, and factors that are responsible for lowering blood pressure that may be deficient in patients with hypertension, like nitric oxide, natriuretic peptide, prostacyclin, adiponectin, adrenomedallin, and the gut and the healthy gut microbiome. So we go on to our case, the case number 1, a 48-year-old male patient coming for a checkup, worried after a friend suffered a myocardial infarction. He is a smoker, overweight, with a blood pressure of 150 over 100. Does this patient have hypertension or not? Now, the definition of hypertension has not changed. It's still systolic blood pressure of 140 or more, or diastolic blood pressure of 90 mm mercury or more, or taking antihypertensive medication, but this elevated blood pressure has to be confirmed on 2 to 3 readings at several medical appointments 1 to 4 weeks apart. But however, there is a continuous relationship between blood pressure and cardiovascular and renal morbidity and mortality, starting from an office blood pressure of 115 and diastolic of more than 75. Now, the grades of hypertension have not changed significantly. There's still based on the systolic blood pressure and the diastolic blood pressure. You don't have to know numbers by heart. But in addition to the grades of hypertension, which are based on blood pressure values, it is also recommended to distinguish stage 1, 2, and 3 hypertension. Stage 1 are patients with uncompleted hypertension without hypertension-mediated organ damage or established cardiovascular disease, including stage 1 and stage 2 chronic kidney disease patient. Stage 2 is patients with hypertension of any grade with hypertension-mediated organ damage or CKD grade 3 or diabetes. Stage 3 hypertension is patients with hypertension with established cardiovascular disease or CKD stage 4 or 5. Measures of hypertension has also been mentioned in the new guidelines. Now, it is recommended to use validated automated electronic devices, quiet room, measure blood pressure in a quiet room with comfortable temperature. There should be no smoking, caffeine, food, drug intake, or exercise 30 minutes before measurement. The patient should remain seated and relaxed for 3 to 5 minutes. There should be no talking during or between measurements. The patient should be preferably seated with the back supported. Legs should be uncrossed, feet flat on the floor, and should have bare arms resting on the table with the mid arm at heart level. And lastly, when we measure, we should measure, if we're using office blood measurements, we should measure it 3 times and take the average of the second two. And actually in practice you'll find that very frequently the first measurement is usually much higher than the second and the third measurement. And if he's doing home blood pressure measurement, then we take the second. We should do it twice, and we take the second measurement. And this is another classification of hypertension based on the discrepancy between office and out of office blood pressure. If the patient have normal office and normal out of office blood pressure, then this patient has sustained normotension or controlled hypertension. If he has high office as well as high out of office blood pressure, this is sustained uncontrolled hypertension. If the office blood pressure is normal while high out of office blood pressure, this is masked hypertension. And this happens sometimes when the doctor is too friendly. So when the patient is with the doctor, he's calm, while when he is outside in the real world, he is more stressed and has a masked hypertension. While the opposite is high office, normal out of office blood pressure, which is white coat hypertension or white coat effect. Now, once we find a patient with hypertension, we have to take a history, do full examination, and prescribe investigations. And all of this clinical process is aimed at knowing 3 main points: whether the patient has primary or essential hypertension or secondary hypertension, what's the cardiovascular risk that's present, and does the patient have any hypertension-mediated organ damage. Now, what is hypertension-mediated organ damage? It depends on the organ. The hypertension adversely affects brain, arteries, retina, kidney, and heart, and each can be affected in different ways. So, the brain, the patient may have vascular dementia, have hemorrhagic or ischemic stroke, atherosclerosis, he may have peripheral vascular disease or aortic disease. In the retina, he may have papillary edema in acute settings or hypertensive retinopathy. The kidney, he may have hematuria, proteinuria, chronic kidney disease. And regarding the heart, the patient may have left ventricular hypertrophy, ischemic heart disease, or heart failure. Cardiovascular risk should be established, and this is the risk of developing a cardiovascular event or a cardiovascular mortality. And the risk increases. This is what we call a heat map or risk stratification. The risk increases with the level or the grade of the hypertension, as well as with the stages of hypertension, the stages we mentioned earlier. So stage 1, the patient does not have any diabetes, CKD, or hypertension-mediated organ damage, but again, the more risk factors, the higher the cardiovascular risk. In stage 2 and stage 3, even patients with high normal blood pressure are at increased risk for cardiovascular events. Now, this is mnemonic for the secondary causes of hypertension that also have to be ruled out. So you have to, first, the A, accuracy, you have to check if the blood pressure readings are accurate. Alcohol, could chronic alcohol use be playing a role? Apnea, does the patient have any obstructive sleep apnea? Aldosteronism, does the patient have primary hyperaldosteronism, where he will have typically also hypokalemia? B stands for breeze and bad kidney. Breeze will be present in vascular hypertension, while bad kidneys meaning renal parenchymal disease. What is it, cause or consequence of hypertension? C stands for catecholamine, coarctation, and Cushing. Catecholamine for pheochromocytoma, where the patients usually have paroxysmal attacks of hypertension with palpitations, tachycardia, diaphoresis, and headache. Are there decreased femoral pulsations and blood pressure that is lower in the lower limbs that happens with aortic coarctation? In the Cushing syndrome, he will have the typical Cushing features. D stands for drugs and diet. Drugs, is he taking any of the drugs that increase the risk of increased blood pressure? Or diet, is he taking high salt diet, highly processed diet, or is the patient obese? E stands for endocrine. especially thyroid disease or hyperparathyroidism, can cause hypertension. E also stands for erythropoietin. In patients with secondary hyperparathyroidism, they can have hypertension because of the increased erythropoietin levels. It's important to rule out the drugs that may elevate the blood pressure, but because in this case it's simply a big part of the treatment would be to stop these drugs, and especially you have to know that the most important group that we frequently find in practice that is at play sometimes in patients with secondary hypertension, and also sometimes it causes chronic kidney disease, are the anti-inflammatory drugs, the COX-2, and the non-steroidal anti-inflammatory drugs. Also, herbal supplements may be at play. Some herbal supplements may increase the blood pressure. Illicit drugs like amphetamines and cocaine can lead to hypertension. Immunosuppressive drugs like cyclosporin and tacrolimus, many of the antidepressants and antipsychotics can raise the blood pressure. Sex hormones, whether given as oral contraceptive or as hormonal replacement therapy, or sometimes even androgens that are taken by some to bulk up and for bodybuilders. Steroids used for many autoimmune diseases can cause hypertension, and sympathomimetics that are sometimes present in decongestant and diet pills can cause hypertension. So decongestants are present in many of the cold and flu drugs that are frequently prescribed and frequently taken by patients. So how do we proceed in the medical and family history? Again, our aim is to assess the hypertension itself. So what about the readings? Had he had previous readings? Has his blood pressure been responsive to treatment? Did he have any experience with previous antihypertensive medications, any intolerances or any side effects, so that we don't re-prescribe the drug? Has he been adherent to therapy? Had he, if it's a female, did she have any hypertension in pregnancy or preeclampsia? Risk factors like family history of hypertension, smoking, dietary history, lack of exercise, weight gain, history of erectile dysfunction that can affect later the drug choice. For example, sometimes beta blockers cause erectile dysfunction, sleep history and snoring, if there is any sleep apnea, any recent stress that caused increase in blood pressure, history and symptoms of hypertension-mediated organ damage, so in the brain and eyes, that the patient have headache, vertigo, syncope, impaired vision, any previous transient ischemic attacks, motor deficits, any previous strokes, cognitive impairment or memory loss. In the heart, that the patient has chest pain, shortness of breath, edema, myocardial infarction, coronary revascularization, history of palpitations, arrhythmias, history of heart failure or symptoms of heart failure, symptoms of kidney disease like thirst, polyuria, nocturia, hematuria, repeated urinary tract infections, or frothy urine as a sign of proteinuria. In the peripheral arteries, you could ask about cold extremities, about intermittent claudication or pain at rest, any peripheral revascularization. We ask also about patient and family history of chronic kidney disease. To exclude secondary hypertension, we suspect it if the patient has young onset of grade 2 or 3 hypertension, sudden development of hypertension or rapidly worsening blood pressure, history of repetitive renal or urinary tract disease, repetitive episodes of sweating, headache, anxiety, suggestive of pheochromocytoma, patients with hypokalemia, suspected of hyperaldosteronism, symptoms suggestive of thyroid disease or hyperparathyroidism, like patients who have removed previously the thyroid gland, any problems during current or previous pregnancies, any intake of drugs that, especially of drugs that we have mentioned. After proper history taking, there should be also comprehensive physical examination. And the first part of the examination is the body habitus, where you should measure the weight and the height and calculate the BMI. But BMI is not the only marker of obesity, and waist circumference can detect patients with truncal obesity who are also at increased cardiovascular risk, and that truncal obesity may worsen hypertension. Again, as we looked for a history of hypertension-mediated organs damage, we also should look for signs, like we should do neurological examination, cardiac examination, fundoscopy to detect hypertensive retinopathy, especially in emergencies, and check for peripheral vascular disease. We should also look for signs of secondary hypertension, like the Cushingoid features or acromegalic features, or signs of thyroid disease or kidney palpation in patients with polycystic kidney. Initial laboratory investigations are also very important. Initially, patients should have their hemoglobin measured to detect any polycythemia, fasting blood glucose and hemoglobin A1C to detect diabetes, which increases their risk and should be appropriately treated if found. Lipids should also be measured, and again, if there is dyslipidemia, it should be appropriately managed. Potassium and sodium, if there is hypokalemia, this may be associated with primary hyperaldosteronism. Uric acid and hyperuricemia may be associated with hypertension. Creatinine is important to measure, and sometimes we measure cystatin C, which is especially beneficial in patients with excessive muscle bulk or with too little muscle bulk. And we don't use creatinine and cystatin C itself, but rather we use it to estimate GFR to check for which class or which grade of CKD the patient has. And as we said, CKD may be a cause or effect of hypertension. Blood calcium should also be measured, and hypercalcemia is present in patients with primary hyperparathyroidism. Urine analysis should be done. Again, we check for the microscopic examination. Are there any RBCs or pus cells if the patient has UTI or if he has glomerulonephritis as a cause of the hypertension? And we check for urinary albumin-creatinine ratio. And again, albuminuria may be a sign of chronic kidney disease in hypertension and can be even present before an elevation or in creatinine and a reduction in estimated GFR. 12-lead ECG should also be done, especially in older cases, to detect if there is left ventricular hypertrophy, myocardial ischemia, any arrhythmias. Further investigations are done as needed and as indicated by the history and the examination of the patient. So back to our patient. His repeated blood pressure, it was once measured in the pharmacy, once in the office. It's still high, 140/95, and in the office it's 150/100. He has normal renal function, normal urine analysis, normal fasting blood glucose, but he has increased LDL-C and decreased LDL cholesterol and decreased high-density lipoprotein cholesterol, the healthy cholesterol. So do we start treatment or not? Now, again, this has changed. It's now recommended, briefly in this graph, you should also only know that if the blood pressure is less than 150/95, we can start lifestyle intervention alone. But if it is above 150/95, in all patients, we should start immediate drug treatment together with initiating lifestyle intervention. And in all grades, we should aim for optimal blood pressure control at least within 3 months, and we should monitor it as if possible with home blood pressure monitor or ambulatory blood pressure monitor, especially in patients with decrease. So again, first step is to initiate lifestyle intervention. There have been progress in lifestyle interventions, and it is now recognized that there are healthy habits that are not common in that are common in non-westernized populations that should be adopted and that lower blood pressure. Not only blood pressure, but they also lower adiposity and obesity, lower glucose, lower blood lipids, lower inflammation, lower sympathetic nervous system activity. While there are unhealthy habits that are common in westernized populations, unfortunately they are also common in Egyptian and in Arabic societies. And these habits are associated with increased hypertension, increased adiposity, increased insulin resistance, blood lipids, inflammation, and sympathetic nervous system activity. And these habits should be discouraged. So, regarding activity, we should promote regular physical activity and prevent sedentary lifestyle. Regarding diet, we should promote a healthy diet that is high in fruits, tubers, roots, and vegetables, low in processed foods, and we should discourage a hypercaloric diet that's high in processed meats, alcohol, sugar, refined grains, and ultra processed food, and high sodium to potassium ratio. There's also an increasing identification of the role of the circadian rhythm, regular sleep-wake cycle, eating during daytime, sunlight exposure, and daytime physical activity in maintaining normal physiology and normal hormonal levels. And actually, it's very unfortunate again that in our societies we have very big disrespect for this circadian rhythm, this natural circadian rhythm that God has created in us, where there is irregular sleep-wake cycle, irregular eating patterns, physical inactivity, and high screen use at night, especially in the youth. Another very bad habit that should be discouraged and should be dealt with accordingly is chronic psychosocial stress. So these lifestyle interventions, the healthy lifestyle interventions should be encouraged, while the unhealthy lifestyle habits should be discouraged, and they should be encouraged and discouraged at every visit of the patient. Now, as our patient has a blood pressure of over 150, over 100, it is maybe preferable to start a drug, and it's preferable to start with dual combination therapy in most patients and up titrate to maximally tolerated doses, and then move on to triple therapy, preferably to give once daily preparations in the form of a single pill combination, because they increase compliance, and the heavy lines, they reflect the combinations that are more beneficial. So the best combinations are either ACE inhibitor or ARB together with thiazide or thiazide-like diuretics, or together with a calcium channel blocker. Second line would be the three of them together. Beta blockers are from the first line drugs, but they are especially preserved to some subgroups, and additional drug classes can be used, but they are usually not in the first drugs of choice. There are also drugs that are beneficial in special comorbidities. If you've heard of angiotensin receptor blocker, neprilysin inhibitor, that are beneficial in heart failure, SGLT2 inhibitors can lower blood pressure or can help in lowering blood pressure together with other antihypertensives, and are especially indicated in diabetics, in patients with CKD, especially with albuminuria, and in patients with heart failure. There are the rise in non-steroidal MRAs or mineralocorticoid receptor antagonists that have shown some benefit in diabetic patients, or especially patients with diabetic kidney disease. Now this is a repetition. Start with dual combination, preferably in single pill combination at every step, and there are combinations with three drugs and dual combination. We should start with monotherapy only if the patient have low risk hypertension or blood pressure of less than 150. If he is high normal, has high normal blood pressure with very high cardiovascular risk, or the patient is frail or old, is advanced aged. So as we said, increase to full dose, and in up to 60%, a dual combination is enough to control blood pressure. If it's not effective at maximally tolerated dose, then we should move to triple therapy, again preferably in a single pill combination, and in up to 90% of patients this is enough to control blood pressure. At any step we can add beta blockers, and beta blockers are especially helpful in patients with heart failure, angina, post-myocardial infarction, in patients with atrial fibrillation, and in younger women with or planning to have pregnancy. If we apply these 3 drugs, sometimes 4 drugs, we have control in about 95% of patients, and true resistant hypertension is only present in up to 5% of patients. Now we have to remember that there are special or compelling contraindications to some drugs. For example, ACE and ARBs cannot be given in pregnancy, cannot be given in women planning pregnancy, in patients with severe hyperkalemia, in patients with bilateral renal artery stenosis. Beta blockers should be given with caution in patients with asthma and should not be prescribed in patients with severe asthma. They should not be given in patients with bradycardia with a heart rate of less than 60 beats per minute. Calcium channel blockers are 2 times dihydropyridine and non-dihydropyridine calcium channel blockers. Dihydropyridine, we fear tachyarrhythmias. They may precipitate lower limb edema. They may not be very beneficial in heart failure, while non-dihydropyridine calcium channel blockers, they have negative chronotropic effect and may precipitate bradycardia. They have also negative inotropic effect, and they inhibit some of the liver enzymes that metabolize some of the drugs, so there is a lot of drug interactions caused by them, and she should be given with caution. Thiazide and thiazide-like diuretics are relatively safe, but they can cause some side effects like hyponatremia, gout, glucose intolerance. They can cause hypercalcemia and hypokalemia, so they should be given with caution in patients with these conditions from the start. Mineralocorticoid receptor antagonists, although they are very effective in resistant hypertension, can also cause severe hyperkalemia and should be given with caution in patients with GFR of less than 30 milliliter per minute. Now we have to be cautious when we're giving RAS blockers, whether ACE inhibitors or ARBs, in patients with CKD. We should monitor serum creatinine and potassium within 2 to 4 weeks after starting or after every increase in the dose. If the patient remains normokalemic with either stable creatinine or increase that is less than 30%, we can safely further increase the dose or maintain on the same dose till we reach the maximally tolerated dose. If he develops hyperkalemia, we should review concurrent drugs, moderate potassium intake, consider adding diuretics, sodium bicarbonate, or gastrointestinal cation exchangers or potassium binders to lower the level of potassium. If there is an increase of more than 30% in creatinine, we should review for causes of AKI, correct any volume depletion, reassess concomitant medications, and stop any unnecessary diuretics or nonsteroidals and other nephrotoxic drugs. Consider that the patient may have renal artery stenosis, and we should review other blood pressure medications, and if the patient has symptomatic hypertension, maybe reduce these other medications. If still there is persistent hyperkalemia or increase in the creatinine, we should either reduce its dose or stop it completely and review the patient's medication. We should also be aware that RAS blockers commonly cause a dry cough, or sometimes patients describe it as shar'a, and it may cause angioedema, especially with ACE inhibitors, that because of the release of bradykinin, but that this side effect is not present with ARB. Together with the hyperkalemia, there may be some metabolic acidosis. ACE and ARBs may worsen anemia, but again, there are multiple causes, especially in patients with CKD. They are always remembered that they are contraindicated with pregnancy, and they can cause incident AKI if the patient develops dehydration or hypotension. So we should always always instruct patients with hypertension that if they develop severe diarrhea, severe vomiting, that they should stop their medications and monitor their blood pressure and not start their medications until the blood pressure rises again. So what is the suggested follow-up for our patient? Now, at diagnosis, we should do full history examination, appropriate investigations, initiate lifestyle intervention and drug therapy, aiming that within the first 3 months we should reach optimal blood pressure. In the first 3 months, the patient should come for repeated visits, and maybe if the patient is far, we can do virtual visits. Now, virtual visits can be done with telemedicine or now with WhatsApp groups. We should always, at every visit, verify lifestyle factors, verify adherence. We should repeat selected lab tests if necessary, adjust drug treatment till we reach the aim of this blood pressure control. Now, on the short term, the patients who are not difficult to treat, they can repeat the visit after 1 year. If the patient has difficult to control the hypertension, or if he is high risk, repeat visit at lesser intervals, so more than once per year. And you should design a checkup program based on the patient. So again, did he develop any hypertension related and organ damage? How is his home blood pressure measurement? How is his lifestyle? How is his adherence? Repeat physical examination, repeat office blood pressure measurement according to the underlying case and according to any previous abnormality. Repeat selected lab tests, ECG, other investigations as needed, and then you should go on checking up on the patient. Again, in low risk patients, maybe every 3 years, and in high risk patients, maybe more frequently, aiming at maintaining optimum blood pressure control. Now, although we used to tell you about this target blood pressure, now there is unanimous agreement that the target blood pressure should be an office blood pressure of less than 130/80 in patients who are 18 to 64. In 65 to 79 years old patients, maybe the blood pressure should be lower than 140/80, but if tolerated, can be brought down to below 130/80. In patients who are over 80 years old, the systolic should be in the area within 140 to 150, and diastolic should be less than 80. Again, with careful revision, the diastolic should not be below 70 for fear of hypotension and fall. In every patient, you should not forget to manage additional cardiovascular risk factors. So stop smoking, lose weight, exercise. If the diabetes is present, treat diabetes. Dyslipidemia is present, treat dyslipidemia. If he has high risk for cardiovascular disease, consider aspirin or other antiplatelet therapy. Now, let's take another case. A 56-year-old housewife, obese, diabetic since 10 years, hypertensive since 7 years, on 2 oral hypoglycemic drugs, on statin, low-dose aspirin, combined ACE inhibitor, thiazide diuretic, amlodipine, carvedilol. Her blood pressure is 160/100. She reports that she sometimes measures it in the pharmacy. It is 180/110. Her hemoglobin A1C is at 8%, which is not controlled, so she had uncontrolled diabetes. Creatinine is 1.6, which above milligram per deciliter, above normal, but we have to calculate it into GFR, and her GFR is 35.4. If we calculate it, 35.4 milliliter per minute. This means she is grade 3B CKD, and her albumin creatinine ratio is elevated. How would we manage this case? This patient has apparent resistant hypertension, which is present in up to 10 to 20% of patients. Hypertension is deemed resistant if, when appropriate lifestyle measures and treatment with optimal or best tolerated doses of 3 or more drugs, fail to lower office blood pressure to less than 140/90. The first step in these cases is to confirm true resistant hypertension, to check either continuous blood pressure monitoring, ambulatory blood pressure monitoring, or home blood pressure monitoring. In the case, she mentioned that even when she measures it outside of the office, it is still elevated. Verify that she is taking her medication. She is prescribed 4 medications, but is she taking them appropriately or not? Are they prescribed at an ideal dose, or should the doses be titrated? And then we should exclude secondary hypertension. So did this patient is diabetic, hypertensive, dyslipidemic? Did she develop atherosclerotic renal vascular stenosis, renal artery stenosis, or any other cause? She's obese. She may have obstructive sleep apnea. We should start excluding these causes. If we exclude causes of secondary hypertension, then this patient has true resistant hypertension, which eventually is found in up to 5%. But one of the causes of resistant hypertension is actually CKD, and the incidence of true resistant hypertension in CKD can reach up to 30%. In all cases, we should adapt and intensify lifestyle interventions and drug treatments. This is an approach to resistant hypertension, especially in patients with CKD, which will take step by step. So again, this goal has changed, but if the patient has apparent resistant hypertension confirmed by home blood pressure measurement, so we have excluded pseudo-resistant hypertension, we should next exclude non-adherence and reduce barriers to adherence. And these are very important in every patient and every disease actually. If the patient's drugs are too expensive and that's why he's not adherent, we should maybe prescribe generics or cheaper drugs, even if they are less effective. But if the patient is compliant on them, he will have hypertension control. Use once daily medications. There is more compliance and more adherence to once daily medication. Combination formulas, and as we said, the first line is to use single pill combinations. Patient education about the importance of maintaining his blood pressure at a normal level. The problem with hypertension and diabetes, chronic kidney disease, they are the silent diseases. The patient may take his medication when he's ill, but actually he may be completely asymptomatic, still have very high blood pressure that will harm him in the future. Assess for adverse effects. Patient may develop side effects, and that's why he's not taking his medication. If the side effects are severe, he may be more compliant to a drug that does not have the same side effects. If resistant hypertension is confirmed, again, very important to initiate and maintain lifestyle modification and evaluate for CKD and other causes of secondary hypertension and start to adjust treatment. Now, the first step in many cases is to change diuretic to maximally tolerated intibamide and chlorthalidone, and these are also thiazide or thiazide-like diuretics. They are not present in many single pill combinations, but they were found to reduce blood pressure more effectively than hydrochlorothiazide, which is the most common thiazide present in combination drugs. If the GFR is less than 30, we may add loop diuretic to existing thiazide, especially if the patient has some edema, and titrate till we reach the dry weight. And if the patient reaches dry weight, we can stop the loop diuretic. The third line would be mineralocorticoid antagonists. And it was found that mineralocorticoid antagonists are especially successful in patients with resistant hypertension. But again, we have to look for hyperkalemia and monitor for hyperkalemia. If this fails, we can add beta blockers, and we can titrate the beta blockers till we reach a heart rate of less than 70 beats per minute, but we should not lower it below 60 beats per minute. If still not goal, we could refer to hypertension specialist, or we should prescribe the less frequently or the less preferred drugs like alpha blockers, central sympathomimetics, direct vasodilators, and clonidine till we achieve control of the blood pressure. Case 3 is a 68-year-old male patient. He's smoker, he's slim, hypertensive, he's not adherent to medication, and presents to the emergency department with disturbed consciousness and weakness on the right side of his body of sudden onset. His blood pressure in the emergency department is 200 over 120 millimeter mercury. This patient has hypertension emergency, which is association of substantially elevated blood pressure with acute hypertension-mediated organ damage. So what are these organ damages? So the brain, he may have stroke, agitation, delirium, head injury. In the eye, he may have visual disturbance, papilledema, or flame hemorrhage on fundoscopy. He may have chest pain or myocardial infarction, signs of myocardial infarction in the heart. He should have back pain or aortic dissection. He could have dyspnea or pulmonary edema, acute kidney injury, eclampsia, or if the blood pressure is high after taking hyperadrenergic drugs, especially acute kidney injury. Now, A patient with systolic blood pressure or diastolic blood pressure of more than 180 or 120 or diastolic more than 120 is called a patient in hypertensive crisis or severe hypertension. But we have to note that it's not the absolute value of the blood pressure, but actually the rate of increase in the blood pressure that is more important. So some patients who had normal blood pressure and develop acute hypertension may have severe symptoms at lower levels. But if the patient has a hypertensive crisis, we should look for acute or impending end organ damage. If they are present, the patient has hypertensive emergency. If they are not present, then the patient has hypertensive urgency. And the associations of hypertensive emergency, we have mentioned them before. Now, what are risk factors for a hypertensive emergency? There are underlying factors and there are precipitating factors. The underlying factors are old age, females, obese, long-standing hypertension, usually on multiple medications, coronary heart disease, CKD, preeclampsia, while precipitating factors, the most common one is non-adherence, or the patient has stopped his medications because he's bothered or for any reason. If the patient takes salt excess, if he withdraws the beta blockers or the centrally acting drugs like clonidine suddenly, then there is actually worsening of the blood pressure. There are the intake of some drugs like sympathomimetics or illicit drugs or non-steroidals or steroids, acute stress or distress, stroke, which may be cause or effect, head trauma in a patient with hypertension can cause, or if a patient has a hematoma that's pressing on the brain, it can cause acute hypertension. So the place to treat hypertensive crisis or severe hypertension is not in the family medicine field, but rather in the emergency department and patients. But you may see patients, and you may. I'm going only to discuss with you the outline of how you treat a patient with very highly elevated blood pressure. The first should look for acute target organ damage. Are there any hints that there are renal impairment or heart disease or visual impairment or disturbed sensorium in any stroke? If they are present, then they should be referred to the emergency department. They should be admitted to the intensive care unit. They should start IV treatment immediately, and with the IV treatment together start appropriate antihypertensive, oral antihypertensive therapy, and to control the blood pressure as you withdraw the IV therapy. And the rate of decline of the blood pressure is tailored to the underlying target organ damage. There are some target organ damage like dissection where you have to lower the blood pressure very quickly to prevent further damage, while in others you have to, like in stroke and intracerebral hemorrhage, you have to lower it very gently to avoid more ischemia to the brain. But in all cases, you should reach target blood pressure by 48 hours. If a target organ damage is not present, then we should confirm persistent elevation after 20 to 30 minutes of quiet rest. And if it is still present, are there any symptoms associated? So maybe not stroke, but does the patient have any hypertension, any nausea associated with this elevated blood pressure? If he does not have any symptoms associated with this elevated blood pressure, we should adjust the long-acting medication and follow him up in 1 to 7 days. If there is any symptoms, we can give the rapid oral agents like sublingual captopril. We can give doxazocine and other alpha blockers that can act quickly. In patients who are edematous, we can give diuretics, especially IV, and we should adjust long-acting medications and maybe keep the patient under observation till his blood pressure is less than 180 over 110, and then he can be safely discharged and followed up within 1 to 7 days. With this, I come to the end of my lecture. Thank you very much. This is my email. If you need if you have any questions and if you need any help, I'm also available in the nephrology department at your service. Thank you and good luck.